Hello, my name is Kaylee Dayton. I'm an ICU nurse practitioner, host of the podcast Walking Home from the ICU, and now an ICU consultant on a mission to help teams become awake and walking ICU through true implementation of the ABCDEF bundle in the ICU. When I started my career as a brand new RN, I was asked in my interview in the Awake and Walking ICU, would you be willing to walk patients on mechanical ventilation? And I was so new, I didn't even know what that meant. And so I emphatically said, yes, of course. And it probably took me about 3 to 8 years to truly understand the magnitude of that question and the impact of those practices. Because in that ICU, it was so incredibly normal to have almost every patient, even on high ventilator settings, awake and walking. And no one told me that was a remarkable practice, that was unusual. So I thought it was completely normal. Now I realize that they are unique in their practices, but that they truly master the ABCDEF bundle. They use those steps to guide them to practice evidence-based sedation and mobility practices. For almost 30 years, they've allowed most patients to wake up right after intubation and walk shortly after. Sedation is only implemented when there is actual necessity, when there's actual indications such as inability to oxygenate with movement, some open abdomens, status epilepticus, severe alcohol withdrawal. These are high acuity patients. There's a detox unit down the hall. So there's a lot of alcohol withdrawal. There's a lot of drug toxicities. There's a bone marrow transplant unit in the hospital. So there's a lot of graft versus host, septic shock, multi-organ failure. It's been kind of an unofficial ARDS unit for years. And so when COVID hit, it became one of the highest acuity COVID units in the state of Utah. Nonetheless, they continue their practice of allowing almost every patient to be awake and moving on the ventilator. And that's why almost 98% of ICU survivors go home. And again, mobility was almost as routine as giving an antibiotic. It was just integrated into the fibers of their culture and their practices. So I left to be a travel nurse and was completely unprepared for the cultural norm outside of that ICU to have every patient sedated and immobilized. And so when I got my first assignment, I wanted to continue my routine of doing a neuro exam, probably get the patient to the chair, waiting for physical therapy to come. And there was nothing about the patient's acuity or diagnosis that would make me hesitate to do so other than they were sedated. And I didn't know why. So I asked my orienting nurse, hey, can I get sedation off and help this patient get up? And she looked at me with panic and said, no, well, they're intubated, which didn't make sense to me because I'd spent years mobilizing at least hundreds of patients that were intubated. And so I innocently said, I know that they're intubated, but why are they sedated? And she looked even more concerned and said, because they're intubated. And I said, but why are they sedated? And she said, because they're intubated. And we went in these circles and couldn't see eye to eye. And that was the first moment that I started to realize that for the rest of the ICU community, being intubated on mechanical ventilation is an automatic indicator for continuous sedation. That as soon as you intubate, you hang the propofol. And that was foreign to me. Yet I didn't understand the real repercussions of sedation and mobility. No one ever taught me what patients actually experience. And I kind of slipped into the same misinformation and myths of the ICU community and believing that sedation was sleep, that patients were as comfortable as they looked, and that was benign. Though I did start to notice a difference in outcomes, that patients were having tracheostomies and discharging to LTACs when I wouldn't have seen that with those same kind of patients in the other ICU. Nonetheless, I took on this when in Rome approach and I continued to practice the way everyone else did. So today I really want to address why it is imperative that we truly implement the ABCDEF bundle within our units and ask questions right after intubation, such as, does this patient have an indicator for sedation? Is it worth the risks and repercussions of deep sedation and immobility for this patient? And even, can we financially afford to fail to implement evidence-based practices with our patients? We need to understand the big picture of our cultural practices. Obviously, patients come to the ICU because they are on the brink of death. They are vulnerable. It is life or death. And I understand that patients in the VA have very special, unique, and considerable risk factors that make them of utmost importance to protect from sedation and immobility and to truly implement the ABCDEF bundle. We have to overcome these long-held habits, myths, and baseless practices in order to save their lives, our workforce, and the financial state of our healthcare system. So today I really want to focus in on delirium and isoquaid weakness, even though there is a whole long list of repercussions of sedation and immobility. But today let's really narrow in on these two. So delirium, I'd heard that word a lot. Of course, I'd worked with it in the Walking ICU. It wasn't with every patient. It was far less common, but I would hear it. I knew how to do a CAM score and things like that. I didn't understand what it was really like for patients. We think delirium is just confusion that's really annoying to deal with. But in reality, delirium is so much more than that, especially for our patients. So I was on a plane ride probably 7 years into my ICU career, and the passenger next to me asked me what I did for a living, and I told him I was an ICU nurse, and the color immediately dropped from his face. And he started to tell me about his ICU stay. Now, this man was in his mid-40s. He looked pretty healthy, didn't have significant comorbidities, but he had an endoscopic procedure, suffered a perforated esophagus, and went into septic shock and required mechanical ventilation for a few weeks. But he barely mentioned the ventilator. All he wanted to talk about was what it was like to have his limbs nailed to the ground in the middle of a forest while trees came crashing down on him. And he couldn't flee, and demons were coming out of the sky, and every few hours something would come to his head and he thought it was a gun. Later he came to find out it was a temperature probe. And of course I wanted to diagnose him, so I said, well, sounds like you had ICU delirium, which meant nothing to him. And I came to realize as I listened further that what he was describing was real to him. He did not feel that he experienced hallucinations, delusions, nightmares. To him, those experiences were just as real as if he had physically lived through them. And many survivors have told me that those experiences are more real than what you and I are experiencing right now. That completely changed my perspective. And I thought, okay, if my patients during my travels were not sleeping, were they really experiencing ICU delirium? Please tell me this was a 1 in a million survivor story. So I went to survivor groups and found that he was one of millions. This is a common thread in discussion on survivor groups, and they experience this at high rates as they've been on mechanical ventilation under sedation and immobility. And I was haunted by what I had learned. And I thought, why aren't we talking about this? Why don't we tell our colleagues and discuss it rounds? Why are we still calling sedation sleep when we know through the research that it is the exact opposite? Sedation disrupts brain activity so severely it can prevent sleep, and that depends on the type of sedation, duration, depth, and dose of sedation. So we can see the rates of delirium correlate with all of that. So benzodiazepines are the worst culprits of delirium, and therefore have the worst outcomes because they disrupt the brain so severely. And that applies to each sedative in varying levels. So by giving sedation, we are depriving our patients of sleep, which is likely one of the main mechanisms by which sedation causes delirium. And this is not just a transient occurrence. This has lifelong repercussions. 1/3 of delirium survivors have PTSD 2 weeks after discharge. 1/5 still have it 1 year after discharge. And this can be lifelong, and this is extremely debilitating. One of the big risk factors for post-ICU PTSD is baseline PTSD, but we also know that sedation increases the risks because it increases the risk of delirium. We also know that real recall and memories of their ICU stay are protective against post-ICU PTSD. So when we're working with a population such as in the VA, when we have war survivors and people that are very traumatized and in baseline psychopathology, they are of the utmost importance to keep awake and mobile and protected from delirium, because they could be reliving their very vivid and real trauma on repeat throughout the time under our care. Delirium is acute brain failure. It's an organ failure, and this acute brain failure can turn into a chronic brain failure that we now call post-ICU dementia. And patients with the delirium are at 120 times greater risk of cognitive impairments, and this impacts the rest of their lives. This can cause severe disability, as they can't even take care of themselves, do daily tasks of living. They have struggles with memory and name recalling and all these things. They lose who they are because of essentially the brain damage they've incurred from delirium, often under and because of our care. Yet the ICU is complicated. So you may say, well, that's really sad, but we're just trying to keep them alive. We're just working on preserving a heartbeat for the moment. If that is true, if all we can focus on is mortality, then we will be especially aware of delirium and especially eager to practice the ABCDEF bundle, because we know that delirium is an independent risk factor for mortality. Patients with delirium are less likely to leave the ICU, twice as likely to die during admission, 3 times as likely to die within 6 months after discharge, and more likely to die 1 year after discharge. With every 1 day of delirium, there's a 10% increased risk of death. And that's why we see that medications like benzodiazepines increase mortality as well, likely because it increases delirium. So that is for our patients, but even for our system, we have to recognize the burden that we take on through our habitual practices. We know that delirium increases length of stay, increases time on the ventilator, increase of workplace violence. When you get people confused and scared and terrified, they're going to lash out at our care providers, which we have seen. And it increases the risk of line and tube removals. It increases hospitalization costs by 39% to have 1 episode of delirium. And those increased healthcare costs continue even after the ICU, after the hospital. The outpatient costs are incredible, as they're no longer able to care for themselves. They require severe and extended rehabilitation. For 1 episode of delirium, the nursing hours required to care for that patient double. So selfishly, we should be very aware and on edge about preventing delirium, because it is a waste of our resource and a burden on our system. And next, I want to talk about isoquaid weakness. Culturally, we've come to assume that if a patient is going to require mechanical ventilation for a prolonged period of time, that they're automatically going to lose the ability to independently breathe, sit, stand, walk, swallow. That is not the norm in the Awake and Walking ICU. As I said, 98% discharge home. They've had very few tracheostomies throughout COVID in their COVID unit. And this is because the isoquaid weakness can greatly be prevented, or at least the severity of it can be lessened, through true implementation of the ABCDEF bundle and prompt mobility. We know that there are a lot of attacks on the muscular system during critical illness. And I won't get into all of this diagram, but it's important to note that of all the things that attack the muscular system, some of the most profound, impactful, and modifiable risk factors are prolonged bed rest or immobility and drug effects, especially from our sedation. And ironically, as we have critical patients coming in at high risk of multi-organ failure from the different causes of critical illness, when our muscles break down, it contributes or can cause multi-organ failure. The muscles are very intricately intertwined with the rest of our body. So this is a vital organ for survival, and yet it gets neglected during critical illness. Out of all the causes of muscular atrophy, such as limb casting, bed rest, things like that, sedation has the most detectable muscle loss within the shortest amount of time. Within less than 7 days, there's massive muscular atrophy. And one of the reasons for muscular atrophy under sedation, obviously, is the absolute disuse. When we sedate our patients, they don't move a muscle. They don't have one muscular contraction, usually, depending on the depth of sedation. That alone can cause muscular atrophy. But what we fail to understand and discuss as part of our risk versus benefit is that sedation also can have a myotoxic effect and be an independent risk factor for diaphragm dysfunction. So when we automatically sedate patients, we're signing them up for higher risks of tracheostomy, prolonged time on the ventilator, months of rehabilitation, and even lifelong disability from that muscular atrophy. And so this is a multidisciplinary effort. Physical therapists can be in the ICU, but if we're deeply sedating our patients, they cannot work with them, and they will still develop this life-threatening condition of isoquaid weakness. And the list of repercussions is vast, such as death, delirium, disrupted sleep patterns, anxiety, agitation, aspiration, pain, DVTs, pressure injuries, falls. Hopefully we all understand that mobility, even especially during critical illness, is a life-saving intervention and a vital part of the ABCDEF bundle. And when we really understand and discuss these risks with our teams, that will help us understand why and then how to implement the ABCDEF bundle. And again, even if we're focusing on just life or death, the 2-year survival rate for ICU patients in general is 67%. But when our patients develop isoquaid weakness and diaphragm dysfunction, which often go hand in hand, their survival rate is 36%. That should be a consideration upon the moment someone is intubated, because what we do in the ICU is going to determine the rest of their lives. But nonetheless, we still have a business to run, a healthcare system to support. So we need to understand that isoquaid weakness increases healthcare costs by 30.5%. Our cultural patterns and habits of deeply sedating every patient after intubation is extremely expensive and a burden for our system. And the main prevention for isoquaid weakness is early mobility, which again cannot be done if patients are sedated, avoiding sedation, prompt nutrition, and glucose control. So this early mobility obviously is progressive. It can start with sitting, standing, and even walking. And this is a 22-year-old young man with Down syndrome. He had a baseline cognitive function level of a 3 to 4-year-old, and he was admitted for mycoplasma pneumonia and mild ARDS. Upon intubation, he was on a PEEP of 12 and 80%, and yet they got him up hours after intubation. And so he never lost the ability to walk, and he never developed delirium. And that is what made him safer and easier to walk. In this video, you have a respiratory therapy student. He was a little bit impulsive as far as sitting down, crossing his legs and doing things like that. So one of his first walks, they were just filling him out. So there were extra people here, but in the end, it took about 2 people to walk him. And after 12 days, he was extubated and discharged straight home from the hospital and continued his life without any impairments. This is Kenneth Hurwitz. He was one of our first COVID patients. He was 69 years old, admitted and intubated. He spent 6 days walking in his room on the ventilator, texting his wife, texting the staff at the desk, telling us what he needed before we came in. And then his lungs got worse and he required pronation, but he was able to pronate himself, do push-ups in the bed, right on the board. And then after a few days, he got a little bit worse, needed some light sedation, and then got worse, could not oxygenate with movement, which then necessitated deep sedation and paralysis. And he had that for about 4 days. So in total, he was pronated for 8 days. And then as soon as he could tolerate being supine, then it was time to do an awakening trial. Once we saw that he could oxygenate with movement, he no longer had an indicator for sedation. So they took it off, got him up right away because he had delirium. They used mobility to help treat his delirium. 4 days after being supine, he was extubated. 10 days later, he discharged home. And 6 weeks after discharge, he went golfing for his 70th birthday. 2 weeks after that, so 2 months after discharge, he emailed me to tell me that he walked 8 miles while golfing that day. At 70 years old, 2 months after surviving severe COVID-19. That is not an unusual outcome in that Awaken Walking ICU, and all is because of how they practice the ABCDEF bundle. And there's so many different ways to interpret the ABCDEF bundle. Again, not every patient and case is the same, but culturally, we have interpreted the ABCDEF bundle as awakening breathing trials and CAM and RAS scores, and that's it, just a checklist. And so we see in this study of almost 20,000 patients in the methodology, early mobility wasn't one of their strong points. There was variation in timing of awakening trials and things like that. Nonetheless, the outcomes were still very impressive and really validate this approach. They found that those that received the ABCDEF bundle were more likely to discharge from the ICU and hospital. Death was decreased by 68%. Now, if that was a medication, there'd be 100% compliance. Coma and delirium decreased by 25 to 50%. Physical restraint use was decreased. So the less sedation used, the less restraints were used because the less delirium developed. Mechanical ventilation decreased. ICU readmission decreased by 46%. Patients were more likely, or were 36% more likely to discharge home. And again, they noticed the outcomes were dose dependent. The more compliant they were with all of the elements of the ABCDEF bundle, the sooner was implemented. The less sedation patients received, the quicker they were mobilized, the better their outcomes were. And again, our normal practices of sedation and mobility are huge financial and legal liabilities for our hospital systems, as they come with life altering and or even lethal repercussions. And we know that even with all the variation, we found that the ADF bundle decreased healthcare costs by 24 to 30%. So by failing to practice the ADF bundle, we are taking on a huge financial burden unnecessarily within our systems. But ultimately, the ADF bundle is, again, not a task list. We can talk about money forever, but in the end, it is about patient-centered care, saving lives for the moment and also giving them lives back that are worth living. I've also experienced, and I've seen with teams that I've worked with, that changing these practices also changes the environment in which they live in. I have clinicians telling me that they were on the verge of leaving critical care medicine because they were so burnt out and traumatized by all the poor outcomes of COVID-19. They were tired of seeing patients trached and pegged and sent to LTAC for almost every patient on mechanical ventilation. But once they started practicing this way, then they started having career fulfillment and wanted to stay. They actually found their purpose and knowing their patients, having true human connection with them, having moments of humanity, and then seeing them get better and walk out the doors. And that's what we're here in critical care medicine for. And that is going to be facilitated through overcoming our cultural habits and practices and turning to evidence-based practices such as the A to F bundle to truly help our patients survive and thrive during and after the ICU. This is what the ABCDEF bundle looks like. And this is what can be possible for the VA system as well, especially for our vulnerable and critical veterans that have done so much for us. It is time for us to fight for their lives and fight to save them from lifelong trauma and suffering, even after they're out of our reach. And that is determined by how we treat them during critical illness. And teams around the world are making these changes. This is a patient on mechanical ventilation and CRRT in Brazil. And they have found that by implementing these things, they have reaped the benefits of all of these promises of the A to F bundle as well. And I'm excited to see the VA experience the same. Thank you so much.